Hello, welcome everyone. Thanks so much for joining us. I see there's more people jumping on here, so we'll just give it a minute or so, and then we'll get started, so hold tight. Hello, everyone. Thanks so much for joining. I see there's still some folks that are meandering into our shared learning group, but I will go ahead and get started. We have a lot to share with you and just an hour and a half with you all this afternoon, or actually it's this afternoon in Pennsylvania. I don't know where you are. Hi, I'm Stacy Nonamaker. I am with NASDI's, which is one of the partners of the Link Center. You'll meet some of our other partners throughout our time together today, so I'll let them introduce themselves when they come on camera. I just wanted to give a visual description of myself. I am a middle-aged white woman with glasses, brown straight hair. I am wearing a multicolored shirt and I'm in front of a white background today. Just some housekeeping things to get out of the way before we jump in. We have live captioning and ASL interpreters with us today. This session will be recorded and the recording and transcript will be shared with all attendees. The PowerPoint and any documents that we review and share will also be shared with everyone via email. So we welcome you to revisit the content and please share the information far and wide with anybody you think would be interested. Attendees cannot see the names of other attendees and all attendees are muted. Please use the chat function in Zoom to communicate with other attendees and hosts in this webinar. And you can do that by clicking the chat at the bottom of your screen. But please be aware that your name will appear in the chat if you make a comment. And you can go ahead and change your name that's displayed by clicking the three dots and clicking on rename. So we have representatives from the Link Center watching the chat and responding throughout the session today. But if you'd like to submit a question or comment privately to the hosts and panelists, you can do that by clicking on the Q&A button at the bottom of your screen. Again, just want to let you know that following the webinar, you're going to receive an email with any materials we review today, including this recording, including the transcript, as well as an evaluation. So we ask that you please take a second to complete that evaluation. We really want to know more about your experience with today's shared learning group. So we know we don't have time to do a deep dive into the topic today, but we're going to start that conversation and about how you can get tools, information, and resources related to the topic of transition. We'll talk a little bit about how we define that in just a bit, but we identify that depending on your experience, some of what we talk about today may be triggering or hard for you. So please take care of yourself and let us know in the chat if there's anything we can do to change the words that we use as we're meeting today. And keeping the shared in the shared learning group, we welcome all sorts of participation throughout the meeting. So some of you may desire to actively engage and we can use the chat to do that. And some of you may just want to listen and witness, and that's okay too. We welcome all of that in this community. As the Link Center, we are beyond thrilled to finally be able to say that we have a website. And so we're sharing that with you all today. You can either use the link that's there on your screen. We'll drop that into the chat, or you can use the QR code to pop onto the website and check out all the good stuff that we've been curating for you all. We have some resources up there and we expect to be identifying more resources, embedding them and getting them on the website. We're also identifying some things that are happening, some events, and talking a little bit about the work that we do at the Link Center. So Take a second and pop up there and let us know what you're thinking. If you do that during our time together, let us know in the chat. Or at the end of our time together today, we'll have an email that you can use. All right, so we are hosting quarterly shared learning groups as part of the Link Center, and we held 2 yesterday for DSPs and clinical professionals. We have 2 today for families and individuals. All of the information in the presentations is the same. We've just tailored it a bit to the audience and changed the discussion questions for each group so that we can pull some information from your experiences and what you're thinking about the topic. All of the content in this shared learning group was from a collaboration of the Link Center partners, people with lived experience, researchers, and those who work on policy issues. And again, just because we get the question all the time and it bears repeating, we're recording and transcribing today's meeting. We'll be writing down all the words people have said, and anything that we share, in addition to the recording and transcription, we're going to email to you after the meeting. So this is the first time that you'll see this prompt, but really we're asking you all, when you think about the topic and as of supporting someone through a transition from a hospital to a community, and as we share with you today, we're really asking you what your go-to resources, trainings, website, or places just to get information are. At the Link Center, we're really looking to elevate good work. And we'd really love to hear from you all about things that maybe we haven't come across yet. So please pop that in the chat at any time during our time together. So today we're really hoping to talk about what we're thinking about, things that we've come across when we think about supporting someone through a transition. And then we're also going to spend some time taking you through an exercise to really focus on getting some ideas and thoughts from you. So that's our agenda for today. But if you want to take a second and just say hello in the introduction or in the chat by way of an introduction, let us know your name, any group, association, or membership you may have. There's really 2 intentions of the shared learning group, and I've alluded to both of them already. The first one is, as the Link Center, we're thinking about this topic that is, we think, so critical in thinking about supporting people with co-occurring conditions. And we want to share with you what we're thinking about. We want to share with you things that we found. But again, really embracing the shared learning group, we want to learn from you all what you're thinking about and what resources that perhaps you have, or thoughts that you may have as we spark the conversation. Okay, so by way of jumping into the topic today, I'm sharing this quote. I know it's rather wordy, but I think it's very important. Transitioning from an institutional setting to a community-based setting, or from a congregate community-based setting to an individual community-based setting, is a time of critical importance in people with IDD's lives. Not only does it represent a time of disruption and uncertainty in people with IDD's lives, how the household is established lays the foundation for people with IDD's long-term stability and security to ensure that they are able to stay in that home. It's a lot, but we are really hoping to present information today from the perspective of a family member and what you can do to push, make happen, or prepare for when we talk about transitioning from a hospital setting to a community setting. We have some other things in the works, like pulling together focus groups of hospital personnel to help us understand what their experiences are of treating and discharging people with co-occurring conditions. And we hope that those focus groups and this shared learning groups will help the Link Center develop strategies, resources, and information for people to have better, more successful transitions from acute settings to the community. So to talk more about that, I would like to introduce Dr. Kimberly Jackson. Dr. Jackson was a family medicine physician in Pueblo, Colorado until 2012, when symptoms related to Ehlers-Danlos syndrome forced her to leave practice. With her slowly progressing health conditions and resulting disabilities, she began working with the Colorado Cross Disability Coalition, CCDC, in 2013 on disability rights in healthcare. Dr. Jackson is appointed chair of the Colorado Prescription Drug Affordability Advisory Council, which works with the Colorado Prescription Drug Affordability Board to make medications more affordable for folks living in Colorado. She also serves on and chairs multiple committees and boards for Colorado Medicaid and is secretary of the board for CCDC. Dr. Jackson identifies as autistic and also lives with post-traumatic stress disorder, in part due to trauma around accessing healthcare for her multiple chronic health conditions and disabilities. Kim, I'm going to turn it over to you. Thanks so much for joining us.
Thank you, Stacy. Can everyone hear me okay? Cool. It's so great to be with you all today, even though we might be thousands of miles apart. At least with the internet, we can join together to work on this really complex topic. And so I just wanted to say to all of you, I'm grateful for you being here, because this is a shared learning group. It's not just about my experience or our experience. We want to learn from you guys as well. And so grateful to have you here today. And just a few things. Stacy, next slide, please. So during the shared learning group today, we're going to be talking about transitioning from an acute care setting to a community setting. And a lot of, specifically for people with intellectual and developmental disabilities and co-occurring mental illness. And so many of us, unfortunately, have experienced trauma, whether it's within the healthcare system or just our living circumstances or things of that nature. And that makes it really hard to recover and move forward and contribute somewhat to the topic we're going to be talking about today, transitioning from the hospitals to the community. Next slide, please. So I want to remind you all, this is extremely difficult work to do. I know I can get very emotional doing this work and talking about it because, I mean, these are individuals that get stuck in a situation where it's very difficult to get out of. And they're part of my community. They're the people that I know. They're people that are like me. And so I just want to remind us all that do what you need to do. If you need to pop off camera, or if you need to mute it for a little bit to take a second, please do that. Whatever you need to do for your own care. And again, just to remember to be gentle with ourselves, because this is really hard work. And this is a starting point, not a ending point for us with the shared learning group, because we know we have so much more work to do. Next. So we celebrate that we are all individuals from different backgrounds, that we all have experiences that other people can learn from, and especially when doing this work. And so we may not have the same viewpoints, we may not have the same idea, we may not have the same thinking, but that's beneficial in a way, because if someone thinks differently than I do, they may have resources I haven't thought about as well. And so just remember to be open to everybody, open to new ideas. That is just really difficult work. So next slide, Stacey. And so we listen, we share, keep our minds open, and remember kindness too. Unfortunately, it's lacking in the world, but we should remember to be kind with each other, because we are trying to do this work. We are all here because we want to make it better. And so, yeah, the better we can work together, the more likely it is we'll succeed. And also just don't judge or blame or victim blame other people. Just listen openly and try not to have critical thoughts about what other people are saying. I know it's easier said than done, but let's hope. Next slide, please, Stacey. So we're talking about a transition, and what does it mean to transition? In this case, it's a change from one form or type to another. In this case, going from a hospitalized or acute care setting to living in the community. And as we know, transition could be a short-term process, especially when it comes to discharging, or it can be a long-term process. And I say process because it's not as much as we would love to have a checklist, if we do all these things and we're successful, we don't have a checklist. And even if we did, some of those items would be changing. And one of the very challenging things that we face is every community is different. Everyone has different resources. And so trying to figure out how to solve this or how to address this issue in other communities can be difficult because they may not have the same resources that I'm used to having or that you're used to having. And as the quote at the beginning said, transitions are often a major shift or milestone. And it's really an opportunity for us to make sure the person has the services they need to live successfully in the community, to be able to get out of the hospital, and that they're going to have that going forward. Again, it's not just you're leaving the hospital, you've got everything fine, because that also then needs to be maintained. And it's a unique opportunity because many people don't get hospitalized frequently. And so we may only have one shot to get this right the first time we're discharging them. And if we don't, either they'll get lost in the system and we may never see them, or they'll end up back in the hospital again. And so just a quick example too from my own life of transitions. I've been hospitalized over a dozen times in my life. I have, as I said, a professional diagnosis of an autism spectrum disorder. I've got PTSD, but I also have a genetic condition that affects so many things in my body. And so I have IV nutrition that keeps me alive. And I get infections a lot and I end up in the hospital. And so last summer, I was in the hospital for a total of 5 weeks, partly for transition issues. And there were a few transitions. I was in New York at the time, and they had to fly me to Colorado because they weren't able to deal with the circumstances that were involved in my life. And then when I got to Colorado, I was in the hospital another 2 weeks and then discharged from there. But while that was happening, my company that supplied my IV nutrition said they wouldn't take me as a patient anymore. I've got aide help, personal care attendants who help me in my home so that I can live independently. But at the time, I only had one. I need 2 or more usually. And so I had to try to figure out all of that hiring. And then figuring out follow-up appointments. There's a lot of stuff in the medical record that really just was distracting, and it just really didn't go well. And even now, I was discharged the end of August, and we're still trying to put some of those pieces back together. And I contrast that with when I was 18 years old, I was skiing in New Jersey, and I had a severe brain injury as a result of a skiing accident. I was in a coma for 8 days and then spent a month in a rehab hospital learning how to walk, talk, and eat again. And it was a very different experience because while I was in the rehab hospital, we were always thinking about, okay, what are the skills that we need to make sure I still have to live independently? And what are the resources that I have when I go home to help with care? And I'm fortunate that my family was involved in my care then. And so they were able to be one of those resources and help me out. And on top of that, I was going to school at the time, and we were able to reach out to the school, and they helped me then transition back into college as well after all of that. And so I give that as a short example of how transitions don't always need to go bad, that they can go well. And some places are better than others at doing that because they're used to that work. And some places, unfortunately, as family members, I'm sure you've seen, it's kind of like the family will take care of it, ... And nobody really follows through with that. So next slide, Stacy. So we're talking about hospital to community, but when we say hospital, we're talking about acute medical care settings. We're talking about mental health facilities and hospitals, and then also too long-term institutions or facilities as well. But mostly just settings that they're very restricted in terms of the person made in the hospital, for example. They may stay in the hospital room the entire time that they're there. They can't just go outside when they want to. They likely can't just go down to the cafeteria when they want to either. And so it's very restrictive and there's not a lot of autonomy. At the same time, being autistic and having executive functioning issues, it's nice because I don't need to figure out a lot of those components. I don't need to figure out how do I get to my appointment because they're gonna wheel my bed down from the hospital to where the appointment is. I don't have to think about meals because I can order from the meal service and get what I want. I don't have to think about buying food or cooking and all of that. And so that structure can, especially the longer you're in that structure, it can start to become comfortable for us. And it makes it easier for us day to day because all of that's taken care of. But then we leave the hospital and we go to the community. So next slide, Stacey. So community, we're talking about usual residences like an apartment, a condo, or a house. The person may have come from home. They may be living with the parents. They may have their own house or apartment or condo. And so if we're discharging them to the community, we need to make sure that that is still in place and stable. But we also might need other things, supported living services, things like home and community-based services that are available through Medicaid, like having home personal care attendants who can come in and help the person with day-to-day activities, with homemaking services, and just make sure that the person is able to stay in the community and live independently as they can and do what they want to do. And so some other community settings, group homes and halfway houses are other examples, and they tend to be a bit more restricted, but not as much as you are in the hospital. And so, I mean, getting people in the community is what we want to do because we want them to be able to make choices in what they want to do day to day. We want them to really live their fullest life, and they can't really do that in the hospital. But at the same time, we have to remember that it's not an easy transition for people with intellectual developmental disabilities and co-occurring mental illness because we lose that structure, we lose that supervision. We suddenly have to figure out meal planning. And we know more, we've seen more and more data coming out that people with developmental disabilities also tend to have chronic illness, a great example being myself. But they may have dietary needs because of their other chronic illnesses that they have to then try to figure out on their own. The resources that are understandable for them might not be available. And it's sort of like, okay, you're going home now and you've done this before, so you must be able to do it now. And we make just a lot of assumptions in general about, okay, the person probably has that, because we really don't think about some of this intersectionality and complicating things like having mental illness, a developmental disability. And for myself, I use a power wheelchair for my mobility, for example. And so that then also limits what I can do, where I can go, resources, and things like that. And two, you have to think about medical needs as well. How are they going to get their prescriptions? How are they going to get to appointments? What sort of transportation is available? And for example, with transportation, a lot of areas don't have effective mass transit systems. Either they're so infrequent, they're not very usable, or in my case, they're not accessible and I can't get on them with my wheelchair. And so there are paratransit services and other services that I might be able to use. But number one, you have to be set up with all of that stuff. Number two, you have to know how to use it. Number three, you tend to have to wait around for a very long period of time. And individuals like myself with a lot of complex health needs, we can't do that. And so, yeah, so there's a lot that we really have to think about just in terms of structure, in terms of functioning, but in terms of living our lives too, and thinking outside of just how do we take care of medical needs? How do I get to the supermarket? How do I go to church? Who are my support who are people who can support me in the community and that sort of thing. And I apologize, I had urgent surgery yesterday on my hand, so I might be a little out of it, but I hope this is making sense. Next slide, please, Stacey. And so ideally, what we're hoping to do is get the person into the community of their choice, whether it was the community they were living in previously or where they want to live. And we want people integrated and engaged in their community as much as possible and as much as they want to be, and really helping them get there beyond whatever barriers might exist that makes it difficult to do that, such as having physical disabilities or yeah, I mean, disability can affect anybody. It doesn't matter how old you are. It doesn't matter what race you are or anything. We can all get disability in an instant and join that club, so to speak. And so with that too, there's a lot of intersectional identities. So I'm autistic, I've got mental illness, PTSD, I've got physical illness, I use a wheelchair for mobility, I'm hard of hearing. I could go on and on. But we have to be aware of the fact that it's not going to be, well, especially just starting off. I mean, it's IDD and mental illness, and it's not just one or the other. We have to look at them together. But then each individual has other identities, LGBT identities, racial identities, cultural identities that then will also influence how they want to access care, how they want to live in the community, where they can access care. And so we really need to be thinking about all of those components as well. Next slide, please. So it's really full engagement in the community. It's really about meeting their social needs and spiritual health needs. I'm an osteopathic physician, a DO, and one of our tenets is that a person is a unit of body, mind, and spirit. And we do pretty well with treating the body with physical medicine. We've got really good acute care that we can do, and we're getting better at helping people with chronic illnesses. And mental health, well, we're talking a little bit about some of that stuff today, but mental health is very important. And unfortunately, the mental health system in this country is lacking in many areas. But we don't often think of social and spiritual health needs, such as support groups in the community. Do they have family in the community? Do they have a spiritual home that with people that might be able to help them out? And do they want to be involved in these things? And how can we help them get involved? And again, with transition and with discharge from the hospital, this might be the only chance we have to do that. And if we can get it all done and get it done correctly, we're hoping to reduce the need for readmission in the future. And that way we can keep people in the community, keep them healthy and keep them safe. Because too, with readmissions and being back in the hospital, number one of the problems that we're talking about today is people are getting stuck because there's nowhere to send them to. But a lot of those support systems that they've set up, the longer the admission, the more likely it is that those are going to start to fall apart. And so we need to, so if they end up getting readmitted, it's going to be a lot of work to get them back to the same situation they were in when they were originally discharged. And ultimately, we want to keep people out of the hospital if we can. I mean, there are certainly instances where hospitalization is appropriate and needed, but ideally, we want to make it so that that's as little as possible. Next slide, please. And so, how do we know if someone's transitioned successfully? And we'll talk through this a little bit with the group exercise, and I would love to hear from you guys too of examples of what does success mean for you. And remembering too, it's patient-centered. Everyone's going to be different. Everyone's going to have different wants and needs. They're going to live in different communities. And so we really need to look at the patient's situation. We need to talk to the patient and talk to their support people if we can, and if the patient is open to it. And really figure out, okay, for this person, not for autism, but for this person, what do we need to do to help with their developmental disability, with whatever it might be. And unfortunately, there's not a ton of data available that we know of, but what data is available, and is there data that we can use to measure success? Are there markers that we can start to kind of come up with that can act as a guide? We've talked about different resources, just things like making sure people have a cell phone so they have access to different care and all of that. And so looking at data, how many people have cell phones? Is it helpful for them? Is that something that we need to do? And is that part of success, making sure that they can communicate, for example? And so, so what does success look like? And again, that's a patient-centered question. Next slide, please. And so I've talked about a number of different points kind of what a successful transition might look like, but what does it look like for you? And if you wouldn't mind, if you could type answers into the chat, that would be wonderful so that we can have a record of them. And because we are very short for time today, and we want to make sure we can get through everything. But I mean, for me, a successful transition means I can go home, I can go to the bathroom when I want and not have to ask the nurse and then wait 30 minutes to go to the bathroom. I mean, something as simple as that, but I'm back in my home. My personal care attendants are working with me again. I've got my follow-up appointments set up, and I know how I'm going to get to them. I have transportation available. because this is all work that I've done with my own discharges in the past that have helped me kind of get situated, so that I have these services available. And then transitioning home from the hospital is a matter of making sure all the pieces are in the right place. So I don't know if there were, Stacy, I don't know if you saw any responses in the chat, or do you want to open it up, or should we just say type in the chat?
But if people, sorry, Kim, not yet, but
Yeah.
if people want to type it in there, we'll engage with folks in the chat. We'll just keep.
Yeah. So if you have ideas or thoughts that come up during any of this, please type them in the chat, and we'll try to respond and whatnot that way as we can, because we do have a lot of material to get through. And so thinking about transition, so what are some of the large scale systems and resources we need to be thinking about? And number one is payment for care, whether it's Medicare, Medicaid, private insurance, or various indigent care and uninsured programs that might be available and that differ from state to state. But the other thing to think about with insurance is too, though, is if we want to get a person set up with services as they're discharged from the hospital, we have to make sure that the insurance is going to pay for those services. Because even myself, there have been times where somebody's made a really good suggestion of some resource or that I could have on discharge that seems great, but then insurance doesn't cover it and there's no way I can afford it. And so that's not very helpful. But I won't find that out necessarily until I'm already home from the hospital and it's too late to kind of go back and rethink that. And so too, we need medical providers and care coordination, because for many of us with IDD, there's data coming out that shows, again, we're more likely to have chronic illness as well as mental health conditions. And so how are we going to get our medical needs, our chronic illness needs taken care of? Who's going to coordinate that care if it's complex? And I think the primary care doc, a lot of times, is kind of the person that's designated for all of that. But does that doctor have the resources? Do they have the knowledge and experience to be able to do that successfully for the person? And again, community mental health systems, mental health care is important for us as well, because we have co-occurring mental illness. And again, the community mental health system and mental health system in general in this country is unfortunately very lacking. We need to think about income, because people need to live. And so that could be disability, so SSDI, which unfortunately can take years to get established with the way it's run in many states. A job is a possibility, but if they've been in the hospital for a while, they may not have a job anymore. They might have lost their job because of it, or they may not have had a job in the first place. And then what support programs are available in the community as well? And are there support programs that we can get people involved in so that they can get access to the social support, the mental support that they need, just from talking with other people that understand what they're going through and what it's like. And transportation too is a huge one, and it's one that we don't think about often unless we've had personal experience with it and need to. Because at least what I've seen, the assumption is, oh, the family will drive you, or, oh, there's Medicaid transportation available, or maybe there's mass transit available. But again, in many places, the mass transit systems are either not accessible or they're not really usable because they're so infrequent. They may not go anywhere near where the doctor's offices and appointments are. And a lot of us, especially with developmental disabilities, we kind of like to live in our caves in our own little world, and we may not have a ton of friends or family members even that have access to cars that can drive us places, which I think is the other assumption. Oh, you'll just find somebody to give you a ride. And we might not be able to do that easily. And so transportation is one of the big things that the disability community worked on first, because we wanted to get people out of nursing homes and back into the communities, but if they couldn't go anywhere, we couldn't do that. There was no point. And so the first battle we fought was getting transportation accessible, and it's much better in a lot of areas because of it, but it still needs a lot of work as well. And so those are some of the larger scale systems to think about, and make sure that, like, okay, where is the person within this system with access to the system with medical needs, mental health needs, income, and all of that. Next slide, please. So we also have small scale systems at play, which in many ways can be even more important and useful than the large scale systems. And there are also smaller resources that are needed. We've talked a little bit about family and friends. I mean, peer support is huge, and thankfully with the internet, it's easier to find other people with rare conditions than it was years ago, but it's still somewhat limited. And we need to think about diet and nutrition. Again, when they're inpatient, somebody's taking care of the food needs, the meal planning, and all of that. But when we get out into the community, now we have to do that. And if that's something we've struggled with before, we're still going to struggle with it, possibly even more so because we're now limited from whatever situation we're recovering from as we come out of the hospital. A sense of purpose is huge. I mean, with all of my conditions, I'm mostly homebound. I deal with severe pain and a lot of other issues. And the only reason I really get up in the mornings is this work and working with all of you and being able to help other people like myself with these issues. And it's so meaningful and so important in my life, and it is for all of us. And that can look different for many people, and depending on what your situation is. I can't work 40 hours a week because of my disabilities, and so I do a lot of volunteer work. I do policy work at the state level too. But for people that can work, employment and having a job, even a simple job, it helps with income. It gives them satisfaction. It gives them, they can meet other people, make friends, and all of that. Or education, going back to school if they were in school previously, or thinking about, okay, what sort of trades or jobs might this person want to work in, and are there educational opportunities that could help prepare them for that? And specifically, I know that I don't know the names, but there are programs out there for people with disabilities where they can learn essential job skills so that it's more likely that they can get jobs and be employed. And so looking at things like that. And then community involvement, especially faith communities and the disability communities, but even the local community. And the more and more that I've dug into this issue with Stacia and we've looked at all of this, we have a lot of systems, large scale systems that unfortunately are broken, that really need a lot of work. And a lot of us are doing that work and we're moving in that direction, but it's going to take a long time. And so getting people out of the hospital now and transitioning to the community now, it really needs to be more of kind of a grassroots approach. Really, how can the community help get this person out of the hospital? What community resources are involved? If you're in the community and you know of someone, okay, well, how can we get the community to rally around these people so that we can help them out and get them out of the hospital? And so family members, you guys are hugely important because you can help us access those communities and access the community and get people really pumped up around, okay, let's make sure we do this right so we can get it done right the first time. Next slide. So today's focus on transition, again, what is a successful transition? What does it mean? It means we all need to work together. It means that we need to start discharge planning from the day the person gets admitted to the hospital. It means doing a lot of the things that we've talked about. But we also, again, have to acknowledge that we might not have influence over other people who can help make transition successful. We might not have those resources available to us. We might not be able to have those conversations with providers as much as we want to. And we might also not have providers who are knowledgeable enough to be able to do this now. And unfortunately, being a family doctor, we're expected to see more and more patients with less and less time. And there's a lot of uncompensated care, as it's called, or time that we spend helping our patients that we don't get paid for. And we've chosen to have a for-profit healthcare system in this country. And so as a physician, I need to run a business and I might not have the resources and the time to become knowledgeable enough about this. And so we're hoping to develop resources so that that's not as much the case, but that it's something we need to think about. Is there another slide after this of mine? I think. Yeah, okay. And two, I've heard stories of people who have been in the hospital for literally months, even though the hospital level of care has been unnecessary for most of that time. And as people get used to, as we get used to living in a situation like that, it becomes more and more comfortable for us. It makes it harder to get out of that because that's now our home and what we're used to. And on top of that, the longer we're in the hospital, the more likely it is that our home outside of the hospital might not exist anymore. Jobs might not exist anymore. And so there may not be anywhere for us really to go. And so that's part of the reason why we might be stuck in the hospital. And then the other thing more and more is just there's a lack of accountability at all levels. And so there's a universal, well, not universal, but there's a lack of responsibility for helping the person. It's really, I guess, the way to put it is I ask people for help for on a certain subject. Oh, that's not my thing. I can't help with that. I really want to help the person, but I can't do that. That's somebody else. But then trying to find that somebody else can be very, very difficult. And there ends up being no accountability. Nobody is responsible for the one thing. And so it gets ignored and it doesn't get done. And so if we want to be successful, as we're saying, we need to make sure all of those components are in the right place. And so we know the system's broken. We know how frustrating it is doing this work and feeling like we're banging our heads against the wall when we are. But what we really are gonna focus on today, what can we do to help get people out of the hospital, to help our family members out? So thank you so much for your time. I hope that was good. And I'm going to hand it off to Wendy Morris, who's another one of our partners at the Link Center.
Thank you, Kim. Wow, such great information and so many beautiful insights. So I'm sure our audience is very appreciative of all your personal examples and transparency, as well as your perspective as a physician. So thank you so much. So yes, my name is Wendy Morris, and I'm with NASHBID, the National Association of State Mental Health Program Directors. I work there as a senior behavioral health advisor, but by training, I'm a nurse. And over the course of my career, I have worked in medical hospitals, psychiatric hospitals, and in the emergency department. And so I bring that perspective to my talking points as well. For a visual description, I am a middle-aged white woman with long gray hair that I curled this morning. I'm wearing a tangerine shirt and I have a white background. Next slide. So the first thing I want to share with you is a resource. This is from the Center for Addiction and Mental Health in Canada. And it's a very easy to read summary. It's actually part of the title, easy read summary. Just some tips that will help people to leave the hospital and have a successful transition. I kind of use this as a guide as I started to put my presentation together, and so just wanted to put it out there for everybody. Stacy has put it in the chat, the link, along with the larger body of work, because this is just one resource that organization has that you might, as a family member, find useful. Next slide. So the first tip, and I think this is true, right, of all relationships, is communication is so important and so key. And so it goes with transition too. There are a host of people that are going to be involved in the transition process in the community, in the hospital, and everybody needs to be talking to each other, share information. What are they learning? What do they know? What does the person who's transitioning need to know? And the team also needs to talk to that person. As Kim pointed out multiple times, you need to talk to the person who's transitioning, as well as their family or any supporters. And I apologize for the background noise. It'll stop in just a minute. The care team at the hospital needs to communicate in a way that works best for the person who's transitioning. And this is really, really critical. Next slide. So as a family member, you might need to give that healthcare team some tips on how to best communicate with your loved one. and to help them understand what accommodations or supports might be needed. Help remind them, use plain language. Please avoid medical jargon and acronyms and things that the average person who's not part of that field understands. Ask if they have visual supports. They have pictures, charts, pamphlets. Are there any kind of hands-on activities like a return demonstration that might be helpful with teaching? Are there videos or apps or other ways that this information could be shared? Does your loved one need an assistive device, and is it available to them as we're doing this planning, having discussions and making decisions and doing teaching? And do they need a support person with them? There may not be somebody there in the hospital around the clock, and maybe the hospital needs to wait until somebody is there with the person if that's what they prefer. The other thing I will say about communication is we know sometimes hospital staff has a tendency to talk to the family member or to a support person who's in the room and not to the person. And this happens whether the person has an intellectual disability or not. It can happen. It happens to my mother all the time because she's elderly and there's assumptions. Can she hear? And so on and so forth. Does she understand what we're saying? So we want to do our best to redirect the staff to talk to the person. And if they still struggle with doing that, be a liaison and repeat to the person what the hospital team is saying. You know, did you have any questions? Did that make sense when they said such another? And try to role model for that hospital team to talk directly with the person. Next slide. We also want to make sure that we are being patient and giving that hospital team some grace. We never know what's going on in the next room or down the hall, how many hours they've been working, how many days in a row they've been working. But we also need to remind them to give the person who's transitioning and you as a family member some patience and grace. This is a very difficult time. We might need to ask them to slow down, ask one question at a time, and allow adequate time for the person to answer. It may take time for them to gather their thoughts or to decide what words they want to use to answer or ask additional questions. Maybe they have an assistive device that takes time. And then also ask the staff to use discussion prompts to check for understanding and not just to, blaze through one topic after another, but to check in and make sure that if there are questions or if we understand what's being said. Let's see, next slide. So one of the biggest things that the hospital team is going to be doing is trying to learn as much about the person as they can to make sure that they're going to be successful and not get sick again when they leave the hospital. So they're going to ask a lot of questions to learn about the person. A lot of different people will ask questions. Some of those questions will be different, but sometimes you're going to get the same question, which can be really frustrating. But if you can think of that as an opportunity, first, it gives all the different people on the team to kind of check, was there consistency? Are we kind of getting the same answer? Or over time, did the person change their mind? Or did they have additional information that they had forgotten to share earlier? Maybe because they weren't feeling well or just slipped their mind. So it's an opportunity every time somebody comes to ask questions and to provide additional information. Next slide. Again, you may need to assert yourself. You may need to encourage your loved one to assert themselves, because a team may not ask some questions that give you the opportunity to provide critical information that they're going to need for a successful transition. So if there's things that they're not asking, but they need to know, put it out there for them. Make sure that they understand that. One thing I have to do with my mom is I have to make sure they know she doesn't want to take pain medicine. She uses all kinds of visualization and she has comfort objects, and this is, we have to work around her desires. Another really big point in working with one of our others, in addition to Kim, had some conversations with another steering committee member, Monica, who really talked about how important honesty is. And again, that's on both sides. We want to be sure that the hospital staff isn't trying to rush our person out the door by sugarcoating things or being evasive. We need to know what services and supports are going to be available, what any kind of new home environment is going to be like. And by the same token, we want to answer all questions as honestly and transparently and as fully as we can, so that the staff has all the information they need to set us up for success. And it's really important not to wait until the day of discharge to ask any follow-up questions or to provide information that hasn't been asked. Do that as early in the admission as you possibly can. Next slide. Really important, right, that the person transitioning be included in conversations and decisions, but also as a family member, if you're involved in their care or you're the support person, you should be included too. So it's important that the hospital team early on identify who the person would like to have with them, or who will be helping care for them when they leave, and make sure that person is involved in the education, in the conversations, and helping the person to make decisions. When transition is done right, it's very person-centered, and it's also an empowering experience for the person. They're involved in those decisions and have a clear say-so about what's happening. Next slide. So this, to the point here, caregivers also need training and support. They should be getting education just like the person about what kind of care and follow-up is needed. And if they don't ask who that person is, we want to be assertive, speak up and share that information with the team so they know. You really need to wait until, her mom is here, so because she really is the primary caregiver, and it's going to be important that she be part of these conversations, for example. Next slide. The other thing we want to be sure is that there's a written plan. Now, hospitals are obligated to give you kind of a written or computer printout plan. If you can get that ahead of time before some of the discussions, it can be really helpful. If it can be reviewed ahead of time so you know what questions you might have, you can use that paper to take notes if you have a pen with you, or maybe to highlight some things. And you also want to be sure that as they're going through that written plan, that you speak up if you need additional information. Can you print off some more information? Do you have a pamphlet? Again, is there a website or a video, something I can learn more because this isn't making a lot of sense to me? Or if the person just doesn't feel ready, there are some things I need in place that I don't feel like you have ready for me. Transportation would be a good example. I really need to figure out how I'm going to get to this appointment before you send me out the door. Next slide. So here's a chat prompt. And if you just could put some ideas you have in the chat while I continue talking. What other tips might you offer about communication? I'm going to spend some time talking about what else should go in the transition plan, and but this is about communication. Do you have any tips for other family members or for individuals as they're trying to transition? Maybe some tips for the hospital staff, because we will be having some conversations down the road with some focus groups doing that kind of work. So what other tips might you offer, either to people who are transitioning or to the hospital staff that are charged with helping? Next slide. So just quickly, Kim talked a lot about transition as a process, and that's exactly right. And the way I kind of view it is, if you think of discharge as an event, right? The day that you leave or the moment you cross the threshold from the hospital back into the community, that's an event. But transition is really a process, and planning for that transition can happen even before hospitalization, as we'll talk about, certainly throughout that hospitalization, and should continue afterwards to make sure everything is going as planned and as expected. Next slide. So hospitals are required to do a discharge plan, as I said, and they are required to start that the day of admission. Unfortunately, It's really only going to be specific to the reason for that hospitalization. So if you've been hospitalized for chest pain, discharge plan is going to be about how to take care of your heart. If you're in the hospital because you broke your leg, your discharge plan is going to be about how to take care of your broken leg. So it's going to include where you're going to go. Are you going to go home? Are you going to a new place? What further care is needed? Is there medication, medical equipment, appointments, those types of things? It really should be a roadmap, that discharge plan for transition out of the hospital, but often it's computer generated. It's going to have very few details. There may be information in there that's not pertinent to you. Maybe you did break your leg and they haven't put a cast on yet because for whatever reason, maybe you have a wound or something, but they print you off stuff about cast care. So because when they go into their computer, right, and what do we need to teach about a broken leg, it might spit out stuff you don't need. The same token, it may not include some stuff that's really important to you. Discharge plans are, again, they're part of the person's medical record and an obligation for the hospital. They're important part of the transition plan, but not all inclusive. Next slide. So as we talk about transition planning, some things to know before we get into the details is to know that the longer the stay in the hospital, the more challenging that transition is going to be for everybody. It just gets more complicated and it gets harder to move, from one place to another. And that even a short stay can be traumatizing. Even a few hours in the emergency room can be very difficult. Think about some of the treatments that a person might have to go through for an illness or injury, like having their blood drawn or getting x-rays or things where you have to be very still. A big loss of control. If you're in a medical center for any amount of time, you're going to have limited options for food. You may have a roommate who keeps the temperature in their room very hot, or maybe they have something on the television you find very annoying, or they have lots of visitors. Those types of things. If you're in a psychiatric hospital, even a much bigger loss of control. They're going to search your person and all your belongings. When you come in, they're going to confiscate things like your shoelaces, your phone. They may take your communication device. So that can all be very traumatizing. And then of course, it's an unfamiliar environment, an unfamiliar routine, and the person's going to be separated from the support system, their loved ones. As a family member, and if they're in a psychiatric hospital, you're likely to be very limited in how being able to talk to them by phone or get in to visit. They're going to be separated from pets, from comfort items. And again, even a short stay can be difficult. Maybe I'm only in overnight, but I missed my favorite TV show, or there was a birthday party for my niece that I missed, that type of thing. Next slide. The other thing we want to remember is that transition can take time. It can take days, it can take weeks in some cases, again, depending on how long the person has been there or if they're having to move to a new home. Anytime that it's possible for the person to visit the new home or to meet new supporters before the transition can be helpful. But regardless, for all of us, when we move to a new home, that can take time. So we want to give ourselves some grace and time to do that. Next slide. So this is just some very general information about what to include in a transition plan. And Kim talked about a lot of this, and a lot of this is kind of basic to that discharge plan. So again, what do you need to know? What does your loved one need to know about their specific illness or injury? What care is going to be needed? Are there precautions we need to take to prevent relapse, complications, or having to come back to the hospital? Are there things I need to look out for that would warrant a call, right, to the doctor or going to urgent care? It should provide a list of all the medications. What is the purpose? Why am I taking these? How are they taken? When do I take them? At night, in the morning, with food, without food? What are some common side effects? Are they going to make, the person sick to their stomach? Are they going to make them sleepy? And when should I call the doctor? If I get a rash when I take this medicine, if I have trouble breathing, there's going to be times when you're going to have to call for help. And then the healthcare team. So who's on your healthcare team? How do you contact them? Under what circumstances should you contact them? And that might include your medical doctor, a therapist, a direct support provider, peer support. Things like follow-up appointments are all going to be on there. Date, time, location. Next slide. So that's all stuff you can probably count on being included, but you need to ask about it if it's not. These items, and again, Kim did such a great job covering this. This is what really makes it a transition plan and makes it more person-centered. Talk about what worked well for the person while they were in the hospital. Were there things about the structure, routine, schedule, or assistance with certain activities like meal preparation, help with medication, changing maybe a dressing on a wound, that made it especially helpful? And are there things that really need to be replicated in the community to make that transition successful? Social support is another big one. How is the person going to pick up their prescription medicines? Not just the ones that they want you to get the day you leave the hospital, but how about when you need a refill in 30 days? Do you need help to take your medications or reminders? How about the follow-up appointments? How will you get there? Who you will go with? And Kim mentioned this too. It came up yesterday in our groups. I talked about, when do you call the doctor? Well, how do you call the doctor? Do you have a phone? Do you have to wait till somebody comes to check on you to access a phone? So those things are all really important when you get into the detail and are really person-centered. Next slide. This is, again, a whole lot of stuff on housing, very important. It might be important to give the person privacy when they're talking to staff about this, so they can be really open about things. Do they like where they're living now, or what they understand their new home will look like? Does it have everything they need? They feel safe, comfortable, they have the privacy they need. Do they like the community and neighborhood? Is it urban? Is it suburban, rural? Does that work for the person? How are they going to get to daily activities like the activity center, or to go shopping, or to church, or to special events if they wanted to go to a concert, or there was, again, a birthday party or something? How are they going to get there? Is there public transportation? Are they going to be able to use that independently? Do they need someone to go with them? How will all of that work? Next slide. So another quick chat prompt: what's not on that list that's important to you? So if there are things you're like, why didn't anybody talk about, blank, fill in the blank, please put that in the chat, because we really want to be able to do that, to capture all of that. Next slide. So these are just some few examples of transition planning, none of them perfect, but all a good resource to maybe get you started. The first is very specific to a medical hospital. It's very comprehensive. The second is a bit more person-centered. I found it very easy to populate on the computer. And the third one, while it's really more about transitioning to independence with healthcare as a person moves from adolescence to adulthood, it's still a good resource that I would recommend. Next slide. I want to talk just for a second about psychiatric advance directives, because if you don't work in the mental health field, you may not know about this. I think most people know about advance directives, and that's when you can say, I don't want to be on life support, or I don't want you to do CPR if my heart stops, right? But there's also a psychiatric advance directive, which is a legal tool that lets somebody with a mental illness state their preferences for treatment in advance of a hospitalization or crisis. The link that you see here, and all these links are going in the chat and will be sent later with the slides, but this link will just give you the very basics. What is a psychiatric advance directive? Why might a person want one? And the very best time to develop these is when a person is feeling well. So remember when I said transition planning can happen before hospitalization? This is a really good example. Next slide. This particular link is very specific to each state. So you can go, there'll be a map or a list of the states. You just click on your state. It'll tell you what the laws are in your state. You'll be able to go to a form if one exists, fill it out. I live in Kentucky. There was a form I could fill out, and it helped walk me through how do I get that to become a legal document. So I would encourage you to visit this. Next slide. Crisis planning is another great thing to do, kind of planning ahead and before a hospitalization or a crisis. Help the person understand the triggers or things that make them feel bad, make them feel sick. strategies, and this is specific to mental health strategies to help them feel better. There's 2 links here. The first, managing triggers. We talked about that when we did our shared learning group on trauma in January. And what to do when I'm not okay, we talked about when we did our shared learning group on crisis last fall. Our website has links to watch both of those shared learning groups if you're interested, but we're also putting just the tools for you to look at in the chat. Next slide. Here you'll see this link is gives kind of a list of what people might want to take with them when they're admitted to the hospital. Again, it's probably not it'll be a little different for a psychiatric hospital because there's a long list of things they're not going to allow you to take. Medical centers, it's a little easier to take what you need. And so if you have a list ahead of time, it makes it a little easier to pack or to ask a support person to get that, or as a family member for you to be able to gather those items. You want to be sure to work with the person to make sure to add very specific items that they might want. Comfort items like a specific pillow. I always take mine with me. Maybe some fidget or sensory objects, maybe extra batteries or chargers for iPads or communication devices, headphones or earplugs to block out all the chaos of the hospital, sunglasses or a hat to, deal with the fluorescent lighting, which can be very agitating. Next slide. So another chat prompt, if anybody has a tool that they use, even if it's homemade for transition plan that you would recommend to others that's really worked for you, we would love if you would share that with us in the chat so we can capture that. Next slide. I want to talk ever so briefly about guardianship. Guardianship is when another person is given power to make important decisions for an individual. And an unfortunate truth is that sometimes hospitals tell people they have to be under guardianship in order to get discharged. That usually happens because they're trying to speed it up or because there's some conflict. They think the person should go here, and maybe you as the family or the person think, we're not comfortable with that. So if guardianship is ever suggested, we would recommend that you call your state protection advocacy immediately and help them talk you through your rights and weigh some of those options. Next slide. Again, guardianship means somebody's going to lose their right to make certain legal decisions for themselves. There's different types of guardianship, but it might be about healthcare decisions. It might be about money. It might be both. It might include some other things, but no one should be put under guardianship unless they really cannot make decisions for themselves. And so we have also here a link about alternatives to guardianship. Next slide. And next slide. We're going to talk about some supporting transition. So just a couple of facts in case you don't know. Thanks to a change in the law, when people are in the hospital for a medical reason, their direct support staff can stay with them, and that Medicaid waiver can still pay for that. And that's going to make it a lot easier for people to have someone they know support them in the hospital. Also, the Center for Medicaid and Medicare Services recently provided information that allows professionals who support a person to get paid to consult with each other on behalf of a person. And that kind of communication is really going to help us to provide person-centered supports. Next slide. Last slide for me. Money follows the person. And this is a Medicaid program. It's available in 43 states in the District of Columbia. It may or may not be available in your state, but this is some funding that helps to for a state to develop services, tools, and processes to help people access home and community-based services when they've been in a long-term, either in a hospital, a nursing home, maybe an intermediate care facility, and they're moving to the community. This slide shows you examples of some things that states do. Every state program is different, but using transition coordinators to work with that hospital team, ensuring timely supports in the community, providing one-time transition costs for those kind of, when you first move into a place, you need to buy certain things, dishes, furniture, that sort of stuff, offering training on person-centered planning. And these supports can go for a full year after discharge. So it's a great resource if your state has it, and you should be able to find that by talking to Medicaid or looking at their website in your state. And that ends my part. I'm going to turn it over to my colleagues, Becky from NASHA, and I think we're going to also have Jules from ASAN. Thank you.
Hello. I can kick us off, I guess. My name is Jules Good. I use they, them pronouns. I'm the programs coordinator at the Autistic Self-Advocacy Network. Rebecca, would you like to introduce yourself? Or Becky, sorry.
Yeah, that's all right. Thank you. Hi, everyone. I'm Becky Wolfkiel. I'm the Executive Director of the National Association of State Head Injury Administrators, and I'm so excited to be here with you today.
Awesome. Next slide, please. So we are going to go over a quick scenario and think about how we can use the things that we talked about in the presentation today, stuff that you've learned about transition, and try to apply that to this imaginary scenario. So I will go ahead and read it. My child Isabel was taken into the emergency room after they started acting confused, not remembering their roommate's name, where they were, or what day it was. Isabel had been there for 2 days before their group home staff were able to convince the hospital staff that this behavior was not typical for Isabel. They finally did a series of tests and found that Isabel had a urinary tract infection that required them to be hospitalized for a few days. Although I live in a different state, I wonder how I can be helpful to Isabel transitioning back home from the hospital. So feel free to provide your thoughts. You can come off mute or you can put ideas in the chat. I know there's kind of a lot to this scenario, so go ahead and take a few minutes to read over it again, think about it. We'll just give you a few moments to yourself here. Emily says in the chat, if transportation is an issue, some pharmacies will deliver follow-up medication. Yeah, that is a great point. So if maybe as a family member or as a parent in this case, if you can help with coordinating the delivery of that medication for Isabel, that could be really helpful.
I was, sort of focused on that very core piece that the caregiver is based out of state. So the role does become more of a coordination role.
Definitely.
Home grocery delivery too, Emily mentions. That's a great point.
Yeah, and the beauty of technology these days is it is a lot easier to coordinate things like that from afar. Obviously not perfect, but easier than it has been in the past. Let's see. Stacy says technology is great. Can this family member use FaceTime or Zoom to call into any doctor meetings to provide any additional context? Yeah, that could be helpful. Obviously, we'd want to get Isabel's consent, but if they are wanting that additional support from their family member, then using that video calling technology could be super helpful. Brooke says, is there someone near the child who can go as a proxy for the parent? Yeah, that's a great question to ask. If in this imaginary scenario, Isabel has another, trusted person in their community that can provide some of that in-person support in coordination with the parent, that could be really good. Kim makes a really good point. I think, yeah, she's talking about the delivery that can help, but might not be affordable for many. Yeah, that's a great point. It's obviously, there's of course the expense of groceries, but also the additional expense that delivery services can incur. So definitely want to be mindful of that, depending on the person's situation. Robin says, constant communication with Isabel to be sure not to miss any needs that may or may not be picked up by those that are local. Yeah, That's also a great point. Not to miss any needs. Yeah, so for maybe people who are close to Isabel physically but may not know as much about her or them, that you do as a parent, like being able to provide some of that insight can be helpful. Emily says, hopefully parents are close in contact with the roommate or the communication lines are open if the daughter is not available or can check in with their daughter regularly. Yeah, so having another person, again, kind of like on the ground that has an eye on things, if possible, can be really helpful.
I think it was Wendy that mentioned earlier the importance of communication. And I think communication with the group home staff has to be, one of the most important lines of communication if they are, the ones advocating for Isabel while they're in the hospital and transitioning out. They have a big responsibility as, as her direct support.
Yeah, absolutely. I also want to point out in this scenario that Isabel had been in the hospital for 2 days before their group home staff were able to convince the hospital staff that this behavior was not typical. 2 days is a long time to be in the hospital with very little support and not having your needs taken seriously. So, another, I think, really important piece of this as a family member from afar is just like really providing that emotional support for Isabel because when you're in an environment like that, it's scary enough in all the ways that we talked about earlier, but especially when you're not being believed by the staff that are there looking over you, that adds a whole other layer of stress.
Absolutely. Stacy comments that Kim mentioned identifying that small scale and large scale resources people have in place is important. If the parent can't be a direct source of support, especially if there is an immediate need, knowing who and what can be additional or in lieu of resources would be helpful. That's such a great point. I think we're thinking about people, but what other small scale supports could be helpful for Isabel during this time as well? Are there other thoughts that folks have or questions, considerations that would help us better think through how we could support Isabel?
Stacy says in the chat, feel free to raise your hand if you prefer to come off mute and share. I think another thing that we had discussed in one of these yesterday, Crystal in the chat just said I'd, but I don't know if there's a follow-up to that. We'll circle back to you, Crystal. There's more to that. Okay, yeah, no worries. Tried to delete and sent it. One other thing that we discussed when we were going through a similar scenario yesterday with folks attending that webinar was, let's say, like, if we're thinking about what Isabel's life looks like a week after she gets back home from or a week after they get back home from the hospital, how will we know that, as a family member, or that this family member in this situation has supported Isabel appropriately. What will be kind of the tells that this transition back home was successful, or as successful as it can be?
That is such a good point and question, and sort of dovetailing from that point was a question that emerged yesterday in another session as well about, what supports are existing in Isabel's residence that may be triggering or traumatizing for her, that we also, or for them, that we also need to ensure are mitigated on, we may assume that returning back to home is a positive thing, but for some it may not be.
Yeah, Emily says, hopefully Isabel will feel comfortable back in her group environment. Crystal says, if she is in group home and got a UTI, have her cares changed, that she needs more help. Yeah, so I think that's a great point. With something like a UTI that, some people suffer from chronic UTIs, but oftentimes they are somewhat preventable or can at least be mitigated to the point where they shouldn't land you in the hospital on a regular basis. What do we need to ensure is changed about Isabel's care routine to make sure that they they don't end up in the hospital for a UTI again? Kim says, burnout is rampant amongst doctors. A recent poll estimated that at least 50% of doctors are burnt out. It's so much harder for the provider to have empathy if they are burnt out. We as patients can feel that, and it can feel like the provider doesn't care. The provider might also struggle to be present and just trying to get through the day. Yeah, that's a great point. I think it's a really tricky thing because, we're thinking a lot about the patient experience and keeping in mind that sometimes the way that doctors can come across might not be anything to do with you and more to do with their working environment. Not that that excuses a doctor being mean to you, but oftentimes that high stress and pressure does contribute a lot to negative patient-doctor interactions.
And Emily says, I would need more information on her actual diagnosis besides the UTI. That's a great point too. There's obviously with the infection, and this has been going on for quite some time. If she's already, who knows how long she was impacted at her group home before she was even taken to the hospital. There's certainly more to the story.
Definitely. Well, good. I think we got some good insight here in terms of how a family member could help in this situation. So, communicating with the family member or with the person that's in the hospital, doing care coordination to the extent that's possible, trying to be in communication with the people on the ground who are more local. Really good insight. So nice work, everyone. Stacy, who am I handing it off to?
Sorry, you'll hand it off to Dr. Deborah Peinels.
Awesome.
There she
Go
is.
ahead, Dr. Deborah Peinels.
I am right here. So thank you. That was a great discussion, really exciting to hear people's insights into what this is all about with these transitions and what it is like from your perspectives. And I just want to reiterate a couple of the things just as we close out with 5 minutes left to go. As Stacy said in the beginning, well, first of all, let me just say who I am. I'm Dr. Deb Peinels. I'm a psychiatrist, and I consult to NASDs on this project as a clinical consultant. And I also work for NASHBIT as the senior medical and forensic advisor and editor-in-chief. NASHBIT is one of the partners that has to do with the mental health leadership across the country. And I am a dark-haired woman with short hair, middle-aged. I wear glasses. I'm wearing a plaid shirt for this presentation with a white background. So I want to remind people to give us your last thoughts about any go-to resources, trainings, websites, or places where you get information about supporting someone through transition from a hospital to a community. Just please continue to put them in the chat or reach out to us later if you think of them afterwards. We can go to the next slide. I want to remind people that our shared learning groups on this topic end today. We have one more left for individuals with living experience. And then on August 20th and 21st, we have our next set of shared learning groups about supporting the whole person. Very important topic to make sure. And I think, as Kim talked about, really important to think about holistic needs. And we're excited to have that dialogue August 20th and 21st. So please, please, please put that on your calendar and sign up to join the conversation. Next slide. Again, a reminder that we have a QR code. You hold your camera over to get you to the link of the Link Center. Here's the link itself, acl.gov/thelinkcenter, or you can email us at thelinkcenter@nasds.org. And I just want to acknowledge Dr. Kimberly Jackson, who sits on the Link Center Steering Committee. Kim, your comments opening us up were really thoughtful and helpful, and you put out yourself and your story in a way that was really palpable and really, I think, helpful to understand some of the complexity of supporting people in transition that helped, really spark the conversation and really have informed this whole process. So I can't thank you enough. We can't thank you enough for your contributions and the giving of yourself to make this work more successful. Also want to just acknowledge all of the partners at the Link Center for contributing to the preparation and content of this meeting. There are many, many partners and really very appreciative of all of that. Want to remind everybody that there is a survey that is placed in the chat for people to comment on how this shared learning group went. Please take the time to fill out the survey. You can, again, just directly link. It's in the chat right now. Next slide. Oh, that was our last slide. So I guess with that, I will close us out and say thank you again. Looking forward to seeing you all at our next shared learning group.